Got folks from all over today. Well, thank you all for joining us for today's Ask the Expert session. It's great. It was great seeing so many of you at our recent conference. I'm Lori Sjogren, and I'll be assisting with today's webinar along with a few of my colleagues. So before we get started, I just wanted to note a few things. First of all, closed captioning is available for today's session. To enable the closed captioning, you just have to click on the closed captioning button that's found on the bottom of your screen, and you select the show subtitles option. Also, questions for our speaker can only be typed in the Q&A button. So the Q&A button is found at the bottom of your screen as well, and we'll answer as many of your questions as time allows. And please just use the chat for communication between attendees and not for questions. So if you do have questions for our speaker, please be sure to put those in the Q&A. So now it is a pleasure to have Dr. Susan Perlman joining us again as our ataxia expert. Dr. Perlman is currently a clinical professor of neurology and director of the Ataxia Center at the UCLA Medical Center in Los Angeles, California. Welcome, Dr. Perlman.
Yeah, thank you. Thank you so much for inviting me back, especially so soon after the convention, which was totally amazing. I mean, Zoom is very convenient. You can bring people in from around the world, but it's two-dimensional. And it was very special to be able to walk around the beautiful setting that the convention was held in and actually see three-dimensional people spontaneously talking to each other, coming up to me. You know, I had the opportunity for a couple of spontaneous sit-down meetings with some of my colleagues that I hadn't seen in person for a few years. And I think a lot of work got done that is a little more difficult to do in the two-dimensional structure of Zoom. I know that one of the birds of a feather that I was facilitating, we came out with 2 action items that I passed on to the powers that be, and hopefully we'll see some movement on those. And with my colleagues, you know, we were actually busy launching a drug trial that hopefully we'll see, you know, some information about in the next few months. So, you know, overall, I had a terrific time.
It really did.
Very glad to see everybody, staff, patients, families, people that I knew, people that I was meeting for the first time, and I hope others who were able to attend in person had the same experience. So, you know, we should probably dive into the questions. So I'm going to open up the Q&A, and we'll start at the top. You know, some of the questions that you're asking might be, you know, already partially answered by somebody before. So we'll try not to duplicate, and we'll try to get to as many of the high points as we can. Now, Michelle has I think, a very important question about the genetic ataxias. Do spinocerebellar ataxia diseases increase expansions as the disease progresses? Now, we know that expansions in SCA, in Friedreich's ataxia, represent unstable areas of the gene. And we know that in research, it's been seen that in blood, for instance, you know, over 10 years, you know, if you do a gene test and repeat it again 10 years later, that the expansion might be a little bigger, since as your blood cells reproduce, the expansion could expand again, small amount. I think the big question is what those expansions are doing in parts of the body that don't particularly turn over. For instance, our brain. You know, the brain cells that we have are the brain cells that we're going to have. We are not making any new brain cells in any large numbers. Within those cells, there is DNA management and DNA repair going on. So it's possible that the expansion, if we did a brain biopsy and then repeated it 10 years later, that the expansion might be a little bigger, but it's not clear that that plays any role at all in the symptoms or progression of the disease itself. Coy has a question. What are your thoughts on rewiring the communication between the cerebellum and the brain? I recently had a physical trainer trying to work with me, starting with crawling and working towards walking. Is there actual science to back this up, or is it a sales pitch? Excellent question. The brain does have the capability to reconnect. You know, somebody who's had a stroke or a brain injury, partially damaged nerves will grow back. And we do have some neural stem cells, some baby nerve cells, as it were, that never developed into adult nerve cells, but are there and could potentially act in rewiring, so that whenever the brain is under stress and there's nerve damage going on, there is a brain response that tries to heal it. Now, things that we know can stimulate that rewiring, exercise, absolutely. It's been shown in the animal models that couch potato mice with ataxia tend to have symptoms come on earlier and progress faster than the mice that are allowed to exercise freely on the exercise wheel. So that, we know that exercise, cardio, for instance, can stimulate nerve growth factors, which can enhance brain health and brain stability. Now, other types of exercise, as you pointed out, the crawling, kind of stepping up of activities to try to re-engage the pathways that work with each other, not an individual nerve cell, but the nerve connecting pathways. And you can train those pathways to have better responsiveness. And I think that's one of the things that exercise is known to do: protects muscle, improves endurance, and it can actually help nerve pathways work better together. So I would say definitely pursue the appropriate exercise, and it sounds like what you're doing does have some basis in science. Now, an anonymous attendee has asked a question about Gen NVG291 from a company that believes it can reverse spinal cord injury, multiple sclerosis, Alzheimer's, by allowing the nervous system to repair itself. After having a mechanism that is purported to be seen. I would like to look up more of the information about NervGen. I'm going to make a note to myself to do that. If this is an agent that is being used in a research setting to explore its ability to stimulate nerve growth factors, promote nerve healing in some of these more common disorders, it could have a role in the spinocerebellar ataxias. Will it completely cure? Obviously, nerve cells that have been lost, reserve that has been lost, is not going to come back, but partially damaged nerves could heal. And I'm going to look a little further into this company and see what exactly they're doing. Another anonymous attendee: does double vision in spinocerebellar ataxia have any clinical signs that differentiate it from other causes, such as decompensated eye, focusing, thyroid issues, etc.? Now, some causes of double vision come from the muscle. So, the thyroid issues affects the eye muscles, enlarges them, makes them, less flexible, less able to coordinate the two eyes on a muscle basis. So that's different from the double vision in spinocerebellar ataxia, which comes from nerve incoordination of otherwise healthy muscles. Many times the treatments are the same. Prism glasses can help, many types of double vision. But there are certainly medications that would work better for double vision in an ataxia as opposed to a double vision from a muscle problem. Now, Susan asks, I always thought that SCA42 was adult onset, but have recently heard of infants and toddlers. So many of the dominantly inherited ataxias that are triplet repeat disorders if the repeat expansion gets bigger when the gene is passed on to the next generation, a typical adult ataxia can begin to present in teenagers and also even in infants. Now, we do know that there are other disorders. SCA5 is a classic one where it's not an expansion, it's a point mutation, and it typically comes on in adults. This is the Lincoln ataxia, but there are children who carry a gene mutation, maybe a slightly different mutation that affects the gene in a slightly different way, where symptoms can come on in childhood and can have a very different presentation. So the National Ataxia Foundation SCA Natural History Study began with the common ataxias, collecting this type of information. And we're hoping that it will expand to include some of these rarer ataxias like Ataxia 42, so that we can learn much more about, what determines age of onset, what determines the way it looks. Then Elise has a question. Am I aware of any studies on cardiomyopathy teenagers? Yes, the FARA website, Friedreich's Ataxia Research Alliance, posts at least 2 studies looking at the cardiomyopathy in Friedreich's young people. And we're getting a lot of information from those studies that tell us more about how the heart changes evolve, why they may look different in an older patient versus a younger patient. And can we expect studies on Omovox, the drug recently approved for Friedreich's ataxia, for teenagers, younger teenagers, at some point this year? I would say yes, that the company definitely has plans to study dosing and side effects in individuals with Friedreich's under the age of 16. But I would not use OMAV or Skyclarys, as it is now named, off-label for patients under 16 until we confirm safety and proper dosing in younger patients. So and I'm hoping that within, the year that we will have that information. Now, Bindu has a question about the effectiveness of stem cell infusions for SCA1. And stem cells have been looked at for many of the common dominant ataxias, ataxia type 3, type 2, type 1. Steminent is a company based in Taiwan and North America that has been pursuing these studies, and there are others as well. I think there's still a lot of debate about how stem cells work. Stem cells can be modified and used to deliver genetic factors, but they also are felt to stimulate nerve growth factors. So the stem cells, as they're currently being administered in spinal fluid, in infusions into the veins, most likely stimulate nerve growth factors, as we have talked about previously, but aren't in a position to replace missing nerve cells. That would take a direct injection of a stem cell that could then fill in a missing nerve area in the brain in a stroke or brain injury, for instance. So I think our knowledge of how effective stem cell infusions are going to be is still very early, and should only be attempted under a carefully designed research environment. Is there a test for gluten ataxia? This is from Linda. Do you test for gluten antibodies? How long does it take for the gluten-free diet to show improvement? So yes, the test for gluten ataxia is to screen for gluten antibodies and also genetic factors that can predispose to gluten sensitivity. The gluten-free diet will show improvement. Think about the gluten-free diet as taking away a stressor that is triggering bad antibodies that can then attack the nervous system. So if you take away the gluten in a gluten-free diet and you allow the immune system to calm down because it's not being challenged by gluten in the diet, the bad antibody levels will go down, and then nerves that are partially damaged may be able to heal. So I have had some individuals who say that within the first 2 to 3 months of a gluten-free diet, they feel different, they feel better for a variety of reasons. But I think for the full impact of a gluten-free diet, you really have to be on it for at least a year. Now, another anonymous attendee, a question from Ben. I was diagnosed with SCA8 in 2009. My 4 older siblings do not have it. My mother was severely struck by lightning, burned her feet, hands, fried her hair, some memory loss, 2+ years previous to me being conceived. Interesting question. Can lightning scramble DNA causing SCA8? And if so, am I now a carrier and are my sons at risk? So the first question I would have is, are there any individuals in prior generations who had ataxia type 8? Now, it's an unstable gene. It's known to, as it were, skip generations, that, a mutation that is very small won't cause problems. A mutation that is very large won't cause problems, but a mutation in the middle range will cause ataxia as you are experiencing. So if we don't have good information about a prior history of ataxia and can, that aren't able to track the gene in your family, I'm going to look up lightning strike and its potential effect on genes in general. Although, our knowledge of, the mutant genes that are produced in, in egg cells in the case of your mother, not clear that the DNA in there, which may have carried the SCA8 mutation in one of her egg cells that then led to you, would have been altered by the lightning strike, but I am going to check that out. However, you now have a mutant gene for ataxia type 8. And that puts your children at 50% risk. You could either, when you had your kids, given them the bad gene or given them the normal copy of that gene. So, this is an important thing to discuss with a genetic counselor. Now, Pamela, good question. Is it possible that hyperparathyroid can cause ataxia? So the parathyroid gland is involved in managing calcium, managing bone health. If it's hyperactive, and many people will have a parathyroid gland, they're little glands right next to your bigger thyroid that are producing too much parathyroid hormone, calcium levels are going up, bones are thinning out because calcium is not getting into the bones. So it's known to be a cause of bone disease. Certainly, it's not known to be a cause of ataxia directly, but I would want to check to see if the cause of the parathyroid abnormality influenced the immune system in some way that could then cause ataxia. So I'm going to look up things to do with the parathyroid and how they might interface with ataxia. We do know that thyroid abnormalities can directly cause ataxia. First of all, the thyroid antibodies can affect the brain. If your thyroid is too active, is too high, it can cause tremor. And if it's too low, it can cause ataxia. So the role of our hormones, as important as the role of our immune system in causing problems all on their own or amplifying the problem that a genetic factor may be causing. Bindu, what is Vico doing exactly? Vico is one of the gene therapy companies that is working on an antisense treatment that is a designer molecule that can target the messenger RNA in, I think, spinocerebellar ataxia type 1. I think they're working on. It's either 1 or 3, and I don't remember. It's going on in Europe. This moiety that they've created and are injecting, I believe, into the spinal canal targets the messenger RNA from the mutant gene, destroys it so it can't make the mutant protein. I believe Vico's approach is what's called non-selective, that it targets the normal messenger RNA and the abnormal messenger RNA. And hence it lowers the production of the ataxia protein altogether, the mutant form and the normal form. It's a phase 1 study. It is not being done in the United States, and they're currently doing dose findings, side effects, etc. What Biogen is doing or has planned to do in the US is similar to Vico, different moiety that they've developed that hopefully will have the same impact. Susan, are there any meds for calcium channel deficiencies, and what do they do? So calcium channel dysregulation is involved in episodic ataxia and also to some extent spinocerebellar ataxia type 6. So there are drugs that are being used now that can stabilize calcium channel activity, which can help stabilize the electrical responsiveness of nerve cells. So that drugs like dalfampridine are one, acetazolamide is another. They have found to be most helpful for episodic ataxia symptoms that come and go. But I do have patients who are taking these and do find that it seems to stabilize the nerve performance overall and may help their ataxia in general. So if you have a calcium channel mediated disorder, the common ones or the less common ones, I would explore, with your clinician, your physician, either acetazolamide or dalfampridine to start. Lori with SCA2 has a question. Does SCA have sleep problems? We know that the cerebellum coordinates everything. Coordinates movement, coordination and balance, coordinates speed of memory and thinking, coordinates our emotions, and most likely is going to have some impact on coordination of the sleep pathways. So there are sleep changes that are very common in many of the ataxias. For instance, restless legs, where your legs feel like you've got to move them. They keep you awake all night because you just got to move your legs. Periodic leg movements of sleep, where your legs are jumping all night, but you're not aware of it, can disrupt your ability to have a normal sleep cycle. Incoordination of muscles in the throat can predispose to sleep apnea and snoring, where, when your body goes to sleep and your muscles relax, the throat muscles relax, are incoordinated to some extent, and cause snoring and may interrupt breathing, interrupting normal sleep. Plus, anxiety, depression, which can often be seen in people who are working with ataxia, can interrupt our sleep as well. So, I think it's important to, consult with a sleep expert if you're having a significant sleep problem, but, think of all the things that you can modify to make your sleep better. Now, do most SCA people develop lower extremity peripheral neuropathy? No. The peripheral neuropathy component of many of the ataxias, it isn't something that's universally seen. Cerebellar problems are universally seen, but the peripheral neuropathy is very specific for certain types of inherited ataxia. And typically it affects the longer nerve pathways. So when you think about the nerves that go into your legs, those are quite long nerve pathways. The nerves that go into your arms are shorter nerve pathways and probably have more resistance, although ultimately you could develop neuropathy symptoms in your hands as well. Now, another anonymous attendee question. I'm a carrier for Friedreich's. Is it true that carriers don't have symptoms? Yes. All the natural history work that's been done with carriers from when the gene was first discovered have not shown any increased risk for anything in the nervous system or the rest of the body. But I do have symptoms. Maybe my symptoms are from another type. So when you say you're a carrier for Friedreich's, are you a carrier of the GAA expansion? And has the other gene that appears normal, no expansion, been tested for a point mutation or a problem, with another aspect of gene regulation? Because I also have patients who have one GAA expansion, have been tested for point mutations. Maybe one was found, they have Friedreich's. maybe one was not found, but their symptoms are so similar to Friedreich's that I would classify them as Friedreich's. However, you're not immune from other things. So I think it's important if you have symptoms of imbalance and are a carrier for the Friedreich's gene expansion, that everything else that could cause ataxia be worked up, including other genetic factors. And this is something that you can engage in with your local healthcare provider. Now, Lewis, my daughter wants to take me to Boston Brigham Hospital in Boston because they have a balance disorder clinic. I live in New York and have been to so many neurologists that I've lost count. Is there anything they can do or tell me that would be a benefit to my condition that I do not already know from the NAF newsletters? There are ataxia centers around the country listed on the NAF website that basically provide the same diagnostic services and the same ability to help manage symptoms, find resources, etc. The group in Boston have been at the forefront of developing better ways to measure ataxia, supporting, our ongoing, search for the best clinical trials for hopefully the best drugs for ataxia. However, if you've been to the Columbia group in New York under Dr. Kuo, they are an Ataxia Center, and I believe can give you the same advice as the Boston group. But I personally have patients who see me once a year, they go to Boston and see the people in Boston once a year, just to make sure that, there's some small new thing that maybe I'm not aware of that the group in Boston has. Now, you may want to explore a telemedicine consult to avoid traveling there, just to, see it, at least as a first step, if there's something that they're doing that is different from what you've been doing so far. Now, Sean, I'm 42 with Friedreich's, and recently I was diagnosed with ADHD. I am currently on 40 milligrams of methylphenidate ER, Ritalin, but I am worried about increasing my dose or switching to an amphetamine because of the heart risk, a very real concern. I get a yearly echocardiogram, which is normal, check my blood pressure daily, average, very normal, have a smartwatch to monitor heart rate and check for AFib, go to the gym 2 to 3 days a week, very good heart healthy regimen. Non-stimulants didn't work for me. Are stimulants something I can continue? As long as you are monitoring, blood pressure, heart rate, as long as the use of methylphenidate at a higher dose or even an amphetamine is not worsening tremor, worsening sleep, I think you can safely use these agents for your ADHD. Some people use these agents for fatigue as well. And it's a balance between potential side effects that you are monitoring versus the benefit that we hope you're getting from these drugs. So, I would say you're approaching, any new medicine very, very intelligently. Now, our next question, let's scroll down here. Brenda, my ataxia was diagnosed 2 years ago. I am 65. It seems like it has progressed rather fast. I read somewhere that the older you are when diagnosed, the faster the progress. Now, if you have a genetic ataxia, the progression, should be predicted by other patients with the same genetic ataxia. Theoretically, somebody with a later onset genetic ataxia might experience faster progression because of the overlap of the effects of aging. You don't have as much reserve as a younger brain. On the other hand, if you haven't had an identified genetic factor, then, there could be non-genetic factors that have caused your ataxia. And non-genetic ataxia, whether it's from the immune system, a vitamin deficiency, or some other factor like multiple system ataxia, do tend to progress faster. So it's important to look for the genetic factors, and there are many that we know can come on in an older person, including Friedreich's ataxia. But it's also important to look for the non-genetic factors whose treatment would be quite different. Now, in my experience, do vestibular exercises help vision in ataxia? I have ataxia type 6. Vestibular exercises can help stabilize the pathways from the inner ear to the balance center. Those pathways intersect with eye movement pathways. So if you can stimulate and stabilize vestibular pathways, often it helps visual coordination, and it's absolutely worth pursuing. Now, obviously, they can also help dizziness, which can improve balance as well. Now, Maria has a question: is there any relation between cognitive dysfunction and ataxia type 7? All of the ataxias that affect the cerebellum may affect cognitive functioning. The cerebellum does coordinate speed of memory and thinking, and this has been documented by Dr. Schmaman in Boston with his cerebellar cognitive affective syndrome, that the cerebellum does more than just coordinate movement and balance. So the cognitive changes seen with the common spinocerebellar ataxias, type 7, type 3, type 1, typically mild, noticeable, but you can usually manage with them. However, spinocerebellar ataxia type 17 may have more severe cognitive changes, so that it's important, if you have a genetic diagnosis, to confirm with your neurologist, what symptoms you're having. Is there something else that's causing your memory problem? Or could it be related to your ataxia? Now, an anonymous attendee asks, is clonazepam good? Depends what you're using it for. Clonazepam is in the Valium family. It can be sedating. People do get benefit for tremor of certain types. Some people will take a low dose at bedtime to help with the various sleep disorders that can complicate an ataxic disorder. Using it during the day can be tricky because it can cause drowsiness. Your body does get used to it, so you may require over time an increasing dose, but it has its place to be used under supervision. Susan asks, does SCA3 affect peristalsis and digestion? Does it affect the GI tract? And I know that was a question from somebody else earlier in the Q&A lineup. Spinocerebellar ataxia type 3, Friedreich's ataxia, and some of the others that affect peripheral nerves may also affect the autonomic nerves that control our bowels, control our bladder, control the GI tract in general, and the stomach. So that if you have an ataxia that also affects the peripheral nerves, not uncommon to have changes in your GI tract activity. Often this can be managed with diet or with very simple medications that are available, but sometimes it can be quite severe and disabling, and you need to consult with your primary care doctor and potentially with a GI specialist. Now, Sue asks, do you think that electromagnetic stimulation therapy for peripheral neuropathy will help me with my balance issues from ataxia? Electromagnetic stimulation for peripheral neuropathy. Now, there's a couple of ways that I've seen it used. I've seen it used to block pain that may be coming from a peripheral neuropathy. And I've also seen it used to stimulate and strengthen muscles that may be becoming innocent bystanders of a peripheral neuropathy. So I think the muscle-directed electromagnetic stimulation therapy to strengthen the muscles might help balance because it will keep the muscles more responsive, but using it to stimulate nerve connectivity rather than blocking pain, not clear that it's going to help ataxia. Now, Nadine has a question. What preventative therapies or treatments exist to address blindness in SCA7? Okay, so there are a variety of treatments that have been used to protect the back of the eye, the retina. And, SCA7, does fall into a category of disorders where the retina can be affected. Friedreich's ataxia, also the retina can be affected. Most of the treatments available for age-related retinal problems would not be appropriate for the genetic problems. They're often targeting circulation and other things to the back of the eye. I know that the gene-directed therapies, whether for Friedreich's or SCA7 or others, hopefully gene therapy will help protect the eye as it helps to protect the cerebellum. These are under development and under research. But, currently, I recommend, some of the eye vitamins that are in use, that are supplements that are particularly helpful for the eye. And this can be discussed with your ophthalmologist. Now, our next question, what do I think of DBS? Deep brain stimulation has been used very effectively in Parkinson's disease to help tremor. And it's been tried in other brain diseases affecting those deep pathways in the brain to help with mobility, and other things that those deep nuclei control. Deep brain stimulation for the cerebellum, I think, not clear from current research that it helps. People have been looking at electrical stimulation of the nervous system for as long as I've been involved in an ataxia world. And it's not clear that invasive stimulation is any more effective than some of the non-invasive stimulation techniques that are currently in testing. And this would be transcranial magnetic stimulation, which has had a couple of successful trials in the US and outside the US. Currently, transcranial magnetic stimulation is available for the treatment of depression, but the placement of the electrodes, as it were, is going to be different from treating depression versus treating ataxia. And I'm hoping that, we will see more development of that field. And then there is direct current stimulation, where you don't implant an electrode, but you stimulate over the area of the cerebellum, over the area of the brain, which is also being investigated. And I would follow this, these areas of research. Is there medication that will help acquired ataxia? This is from Tamikia. Number one, with acquired ataxia, if you know what the trigger was it the immune system? Was it some other factor? Obviously, you treat that factor. You work with the immune system. You deal with poisons and toxins. You deal with vitamin deficiencies. Symptomatic medications, however, could help the acquired ataxias as they help the genetic ataxias. So you mentioned dizziness. There's a long list of medicines that are used to stabilize dizziness and stabilize nystagmus, the abnormal eye movements, and these are listed on the NAF website. The long list of medicines used for tremors of all types. And for balance, currently dalfampridine is something that has an off-label use for balance, and riluzole, which is approved for Lou Gehrig's disease as a neuroprotective agent, also has a large off-label use for balance as well. Then Ken has a question, does SCA type 13 cause cognitive issues? If so, how severe? Now, this is something that I would have to go back to the website, my favorite website, the neuromuscular homepage, to look up SCA 13. My impression is that as an ataxia, it's going to cause some mild cognitive issues, but I don't know how severe. Now, some of the ataxias that are not due to triplet expansions, but are due to point mutations, as we had talked before, can cause an adult ataxia, can cause a childhood ataxia. Now, some of the childhood versions of SCA5, et cetera, may have more prominent cognitive and learning issues than the adult form of those disease. So I apologize, I'm going to have to look up SCA 13 and check on what is known about its impact on memory. But this is a website you can also go to. It's called the Neuromuscular Homepage from WashU. in St. Louis, and it's a wealth of information about all the genetic ataxias. I've seen people on Facebook that refer to cerebral ataxia. Is this a typo? This is from Shannon. I thought SCA is cerebellar, not cerebral. I think to some extent, cerebral ataxia is a typo, as it were, or a miscommunication. A lot of the letters are the same as cerebellar, and it's easy to mislabel it. However, you can develop ataxic symptoms from the cerebrum, which is the larger area of the brain that overlies and communicates with the cerebellum, that is a smaller area of the brain in the back of the head. So that somebody that has had a stroke or some problem affecting the frontal area can have incoordination that mimics cerebellar ataxia. So, previously this was recognized before genetic factors were known, and, they had creative names for a frontal lobe stroke that could cause, cerebellar type symptoms. Bruhn's ataxia was one, the ataxia of Gorebitzhoff was another. But I think we now recognize that the cerebellum communicates with the upper brain, and that communication back and forth can influence cerebellar symptoms. But I think you're right. Referring to cerebral ataxia most likely is meant to be cerebellar. Now, Louise has a question. Could you tell us the medical centers that offer a telemedicine consult? We are in Columbus, Ohio. So within the state, within Ohio, within California, since COVID, one of the few good things to come out of COVID is greater acceptance of telemedicine consults. So that in your state, if there is an ataxia specialist or a movement disorders specialist that sees patients with ataxia, you should be able to set up a telemedicine consult, at least as an initial interaction. The problem is when you're crossing state lines. Now that COVID is to some extent, on its way out, payment for telemedicine consults across state lines typically is no longer occurring. So that if I wanted to do a telemedicine consult from California to an ataxia patient in Arizona, that consult would not be covered by the patient's insurance because it crosses state lines. And I think this is something that, we need to work on, another action item, about telemedicine across state lines, that we need to bring back funding for that, since I think telemedicine is here to stay. Now, Beverly has Scott too. Any information positive or negative on using electrical stimulation of the cerebellum? And we've already talked about that. Direct current stimulation, as well as transcranial magnetic stimulation, do seem to have a positive effect and are under active research at this time. Louise has a question about the difference between spasticity and muscular rigidity or stiffness. So spasticity is an increase in muscle tone caused by a defect in the upper motor neurons. The upper motor neurons, which go from the top of our head down to individual muscle groups, control muscle tone. They keep muscle tone flexible and normal. And when upper motor neuron signals have been blocked or damaged, the tone automatically increases, and that is spasticity. Muscle rigidity, if we look at the typical way rigidity is used, comes from a different part of the brain that's involved in muscle tone, and that's the basal ganglia. So that when the basal ganglia have been targeted in a form of ataxia, SCA3 is typical, and there are others, then that pathway that is involved in muscle tone causes rigidity. It sometimes can be mistaken for spasticity, but the treatments are very different. Sometimes, Botox injections can help with spasticity or rigidity, but medications that are taken for spasticity are quite different from those used for rigidity. And stiffness in general, if you have a muscle that, has been weakened, because of disuse. It's harder to use that muscle because it's harder to walk. So you spend much of your day sitting, and the leg muscles are not being used. Or the nerve supply to that muscle has been compromised in a peripheral neuropathy, and the muscle becomes weak. Weak muscles that are disused, can stiffen themselves. And the stiffness is often painful and is usually treatable with physical therapy modalities. So again, if you feel that your muscles are tight or stiff, it is important to discern spasticity versus rigidity versus a problem in the muscle itself. Now, our next question is from Patricia. Do you think that amantadine may help? Amantadine is one of the oldest off-label drugs used for ataxia, used for tremor, used for fatigue. It was originally developed, I'm told, as an anti-flu agent, was fortuitously found to help mobility in Parkinson's disease, and has, for my entire career, been used off-label for ataxia, for tremor, for fatigue that often accompanies ataxia. It's safe enough to use in children, but it does have side effects. It's constipating. It can cause dry eyes, dry mouth. It can cause swelling of the feet and ankles. So someone who is using amantadine has to balance off the good effects versus these potential side effects. And usually if you're on amantadine for 6 to 8 weeks, you should be able to tell if it is helping. Now, Tamiki again, are you taking new patients with acquired ataxia, and are there any clinical trials that you know of for acquired ataxia? Acquired ataxia is primarily treated by treating the cause of it and then using symptomatic management. So I am currently not aware of any clinical trials for acquired ataxia, but symptomatic drugs for ataxia could be used, whether it's genetic or acquired. So, keep amantadine in mind, keep riluzole in mind, etc. Now, Karen has a question. Let's scroll down. What do you think about whole body vibration therapy? I have patients using it. They feel that it, is standing on the vibrating plate, I think is the technique you're referring to, does seem to stimulate muscles, stimulate muscle tone, normalize muscle tone, may have an impact on any pain or peripheral nerve pain-related symptoms. I don't know that it helps balance directly, however. Now, Remo, from his iPhone, my 3-year-old was diagnosed with ataxia. She walks since 19 months of age. She improved her walking, started to ride a scooter. Can we assume, based on the slow progress, that her ataxia is not progressive? Okay. It sounds like this was something that came on, early, even though she did, develop walking. It was a slightly later age. Walking seems to be getting better. She seems to be regaining some milestones, although, maybe at a later age than some of her peers. If there is some progression of symptoms, it sounds like you rate it as slow. And in this early age group, we are dealing potentially with a genetic factor. And I don't know if a genetic ataxia was found in your child, but you're also dealing with normal brain development, which goes on behind the scenes. So that even very young patients with a genetic ataxia can have periods of gaining motor milestones, maybe at a later age, plateauing and seeming to have very slow change. But if it is a genetic ataxia, it will typically progress. And then often, with these very early onset ones, stabilize in an individual's 20s. But then when aging kicks in after the age of 30, progression may be seen again. So determining whether the ataxia is non-progressive, and indeed some of the early onset genetic ataxias are noted in my favorite website, neuromuscular homepage, to be non-progressive, it's important to really, find out the genetics of it. Now, Verdell, what is the difference between SCA3 and SCA6? So the numbered SCAs, which are now up to SCA50, represent different genes that have been compromised, mutated, that have an important role in the cerebellum. So SCA3 and SCA6 are different genes that, when mutated, seem to target the cerebellum for dysfunction. So the difference between them is the individual gene itself. The SCA3 gene seems to have an important activity that is seen to compromise the nervous system earlier, while SCA6's gene dysfunction doesn't have obvious problems in the nervous system until a little later in life, implying some compensatory pathways or other things that the nerve cell can use to overcome the SCA6 compromise. SCA3 also affects pathways outside the cerebellum. So there may be a peripheral neuropathy, there may be upper motor neuron spasticity, there may be basal ganglia rigidity that can add to the ataxia symptoms, while SCA6 in general tends to be pure cerebellar. I know there's been some research suggesting that there may be some mild impact on areas outside the cerebellum, but I think it's recognized that its primary target is the cerebellum. So what we know about the behavior of these genes, their normal function, and the behavior of the mutations helps us understand why the common dominant ataxias can look the same, but can also look very different. Okay, so Henning is asking, can I repeat the off-label medications to improve balance? So going back in history, amantadine is one, and these are listed on the NAF website. Riluzole is one that has been accepted by the American Academy of Neurology as having appropriate off-label use for ataxia. Dalfampridine is one that we spoke about for the episodic ataxias, but also may have a role in stabilizing ataxia off-label. All these drugs are available generically, so that the cost is less. Insurance coverage may be available, even though they're being used off-label, but there are discount coupons that are available online that can help you at certain pharmacies get these drugs at a reduced cost. And then Renee comments, telemedicine for international patients would be awesome. I agree. Verdell, what are the results of trials that have been done on mice? Were cells repaired? Now, we have to remember the mouse brain is not the human brain. And, mouse tissues with various, for instance, gene-directed therapies have shown recovery. Will we be able to get the same results in a human brain with any of the gene-directed therapies, for instance, or other therapies that can stimulate nerve healing in the lab? We have to wait and see. Marie, can left side atrophy cause ataxia? Now, if you're referring to left-sided atrophy of the brain, we were talking about areas outside the cerebellum that communicate with the cerebellum, and if damaged, can cause ataxia-like symptoms. Left-sided atrophy, if it's left-sided muscle atrophy, wouldn't be expected to directly cause ataxia, but because of the muscle compromise, muscle performance, even with a normal cerebellum, is going to be off because of the weakened atrophic muscles, and then everything in between. Now, Ray, blood work and genetic testing were both negative as a cause of my ataxia. Where do I go from here? I hope that your DNA has been banked in one of the regional or national genetic research groups for further genetic assessment. Like I say, we're up now to spinal cerebellar ataxia type 50 and have recently discovered two recessive genes, the canvas gene and the SCA27B gene, which can occur without an obvious family history or with a family history but misdiagnosed. These are new genes, one recessive, one dominant, that have been recently discovered. So if your DNA is banked in a research group, it is still working for you. However, looking for acquired causes and then dealing with physical therapy and other medications to help your symptoms can absolutely improve your quality of life. Now, Helen, can lupus cause ataxia? I am 85, diagnosed 4 years ago with, I presume diagnosed 4 years ago with ataxia on the foundation of a prior diagnosis of lupus. It's not clear from your question, but lupus is an autoimmune disease. Typically comes on in younger individuals, not children necessarily, but young adults. And the immune system dysfunction can affect any part of the brain, the nervous system, the body in general. If you've carried a diagnosis of lupus for many years and still have active bad antibodies, it could be a factor in a later in life onset ataxia. And again, this needs to be discussed with, with your treating physician. Now, Michelle, what is my opinion of Skyclarys for Friedreich's? I was diagnosed 20 years ago, wheelchair bound, has been seen at UCLA. The two things that Skyclarys, Omovox alone, has been shown to do in Friedreich's. Number one, in the first 6 months of the study, MOXIE study, sponsored by Riata, there was an improvement in symptoms. So there seemed to be symptomatic benefit, which I think anybody at any stage of Friedreich's could benefit from. The second thing that was noted in patients who stayed on Omovox alone for 3, 4, 5 years now is that it seemed to slow progression. So for somebody who's been symptomatic for over 20 years, using a wheelchair, may have difficulties in hand coordination, et cetera, slowing progression might not be as obvious as potential symptomatic benefits. And I would recommend trying it for at least 6 months to see how you feel on it. Now, Karen has a question. Is involuntary hand movement part of ataxia? And is there anything to do for it? This is an individual with hereditary spastic paraplegia, which can include symptoms of ataxia. So involuntary hand movements, if we're talking about tremor, absolutely part of an ataxia and could be seen in your variety of hereditary spastic paraplegia, and there are a number of varieties that have been found. Involuntary hand movements coming from the basal ganglia, different part of the brain outside the cerebellum that may be affected in the ataxias, have been seen in some of the ataxias as well. And these are referred to as chorea, or myoclonus in a related part of the brain. So these involuntary hand movements can interfere with hand coordination, and whether it's due to myoclonus or chorea or tremor would be treated in different ways, and certainly should be treated if they're interfering with your daily activities. Then Gail is asking about rapamycin, and I know there have been clinical trials of rapamycin in neurogenetic disorders. And I'm going to have to go back to the literature and look to see what the experience has been with the ataxic disorders. And I think we're at the top of the hour now, and we're going to have to stop. There are so many good questions, and I've been taking notes of some of the questions that I couldn't answer right off the top of my head. And I will get back to Lori about these answers, and hopefully she can track down the people who asked them and post some additional information about them. So thank you so much. I wish we could go on, but I'm sure that the next time that we're hopefully going to have another Ask the Expert webinar that will have even more new research to discuss and more things to share. So thank you all.
Thank you so much, Dr. Perlman. We had another great session with great questions being asked. So thank you all out there that are attending that asked such great questions. And it's, as I said before at the top of the webinar, it's always a pleasure having you as our expert, Dr. Susan Perlman. Thank you so much. And I did mention early on in the chat in the webinar, a recording of this webinar will be available on our website, on our webinars webpage. So look for that, and then also check out all of our past webinars on our webinars webpage, and it'll also be available on NAF's YouTube channel. So I think that's all for today. So until next time, take care, everyone, and thank you again all for joining.